Alhamdulillah, okay, Alhamdulillah. So basically, nama saya Alwi, saya training lecturer pediatric dekat UIA. So today I'm going to present to discuss many discussion with you guys on diabetes. Okay, diabetes in pediatric. So the focus is actually even though this particular slides is actually I borrowed from Dr. Rashdan Zaki. He's a pediatric endocrinologist in Hospital Raja Perempuan Zainab II in Kota Baru. So the focus is actually, even though the title is how to adjust insulin, but I think this is beyond the scope of our discussion. So the focus is mainly on the management of diabetes in terms of diagnosis, and also the main focus of treatment, okay, and management of diabetes itself. Okay, I think we can start. So diabetes, okay. So the outline is actually first understanding diabetes, and then understanding what insulin is, why intensive insulin. Okay, basically there are two types of insulin therapy. We've got basal bolus and also we've got intensive insulin and also just insulin lah, not non-intensive insulin therapy. So intensive, you've got basal bolus and also the CSII lah, the continuous insulin pump. And then transition, okay, number 4 I'm not going to focus. Then number 5 is I will cover a bit, but not all, okay, because it's a bit too technical. So understanding diabetes and the science behind it. Okay. So any of you know how many diabetes you know? Can one of you answer me? Any diabetes that you know? Any type of diabetes that you know? No one?
There is a type 1, type 2.
Okay. Type 1, type 2.
So there is a MODY.
Okay, good.
Yeah. And then I did.
Okay, good. That's very good. Okay. So I'm focused on the pediatric, so I'm not going to bother about gestational diabetes in adult, kan? So in general, in pediatric, diabetes can be divided because there's a lot of advancement in diabetes, especially the genetic of it. Okay, genetic of it. Before this, we are talking about when we talk about diabetes, we only talk about type 1, type 2, and then we are talking about the metabolic syndrome, the environmental part of diabetes. But now a lot of research being done, a lot of genetic known to us lah. So in general, diabetes can be divided into two. Okay, you can divide into monogenic diabetes and also polygenic diabetes. Okay, this is based on the etiology lah, based on the etiology and based on the molecular aspect of the diabetes itself. So it's polygenic and also monogenic. So monogenic diabetes is a diabetes that has with high genetic penetrance, and it is caused by a single genetic defect. Okay, so understand. So basically, the monogenic diabetes is diabetes. We can call it a genetic diabetes. Diabetes caused by genetic problem, and a lot of these monogenic diabetes arise from a single defect, either gain of function mutation or loss of function mutation in a specific gene or specific locus of the chromosome. So included in the monogenic diabetes are the congenital diabetes, and its syndrome, the spectrum of congenital diabetes. We've got the Danon syndrome, the congenital diabetes, and various presentation of congenital diabetes, which itself is another lecture. Okay, hold on. Okay. So and then second, we've got the and also monogenic diabetes include MODY. MODY is also a monogenic diabetes. There's a specific gene for MODY. And then the second one is polygenic diabetes. So polygenic diabetes is type 2 diabetes, gestational diabetes, which of course there's a genetic component of it, but usually it's caused by a multiple genetic defect rather than a single genetic defect, and there's a lot of association. It's actually an interaction between environmental factors and genetic factors. So those with the genetic factors has higher risk to develop the polygenic diabetes, but most of the time it requires trigger from environment. Okay, by the way, if you got any question, you can ask. Okay. So diagnosis, how to diagnose diabetes mellitus. So in general, the diagnosis is similar in pediatric and in adult. So first, there's classical symptoms of diabetes or hyperglycemic crisis, okay, or hyperglycemic crisis with plasma glucose concentration more than 11. Okay, and then fasting plasma glucose more than 7, 2 hour post-load glucose more than 11. Okay, and HbA1c more than 6.5. Okay, previously we don't use HbA1c to diagnose, but now it's actually HbA1c supported with classical symptoms, and also one of the other 3 criteria can be used to diagnose diabetes. Okay. Okay. Any questions? Diam kat sini. Sorry, hold on. Okay. So far, am I too fast or okay?
Okay, Doktor.
Okay kan? So background understanding of type 1 DM. So this is the most common type of diabetes in children and young adolescent. Okay. It is a state of absolute insulin deficient. So it's not insulin insensitivity, but rather insulin deficient. Okay. There's a genetic susceptibility for type 1 DM. So HLA, DR3, DR4, DQ2 or 8. So actually some center, for example, the Scandinavian, okay, DM type 1 is very common in Scandinavia. Okay, the prevalence is up to 1 to 2%, if I'm mistaken, in pediatric population of Scandinavia. So they did a lot of screening program for type 1 diabetes, where they actually screen. They screen for the presence of HLA-DR3 and 4 in all the pediatric population, especially those with family history. Those in a family with siblings of type 1 DM will be screened. And these children, okay, what they did is they start steroid early on. Because if you look at the progression of type 1 DM, it's usually started with destruction of, it's a slow progression of the destruction of beta cell. Okay, because once you've got no beta cell, then only you will become diabetes. Okay, as long as you've got some beta cell, functioning beta cell, you will not become diabetes. Okay, so what they did is they prevent the development of they slow the development of diabetes by using prednisolone to prevent to reduce the inflammation of the pancreas and the beta cell. And usually it's associated with environmental triggers such as virus infection, and also some studies demonstrate early exposure to cow's milk, and therefore breastfeeding is actually protective of type 1 DM. So this is the clinical progress. So usually the initial beta cell mass is normal initially, but over time, once they start the environmental trigger in those with genetic predisposition, so they start to have insulitis, which is the beta cell injury. This is what the early part is when the early part is where the screening plays a role, where they actually, those with genetic predisposition, okay, they can monitor insulin level, they can actually start steroid early to prolong the time. Okay, so finally autoantibodies develop, and this leads to the final stage of diabetes. No? Okay. So what happens in diabetes? Because insulin is required to shift glucose intracellular, so from intravascular to intracellular. So however, without insulin, okay, the glucose cannot enter the cell and cannot be metabolized. And as you know, some tissue are very sensitive to glucose, especially your brain. Okay, the brain. So when there is no insulin, there'll be no glucose into the cell. So the cell become hypoglycemic, become acidotic. So they've got intracellular acidosis. And also the glucose itself are very highly osmotic molecules. So it will actually cause sort of dehydration lah. And also it will increase the osmolality of the blood. And that's what cause all of the symptoms, because glucose is a small molecule, so it can actually filtrated through the glomerular basement membrane, and it will attract water, kan, because it's highly osmotic, so it will attract water that leads to all the symptoms of polyuria and then polydipsia, so on. Okay, hold on, sorry, ada gangguan sikit sekejap, hold on, can you give me like 2 minutes sekejap. Okay, so this is type 2. I think type 2, you guys all well versed. I'm sure you've got teaching by IM, kan? Okay, so presentation of type 1 DM. By the way, any questions? You can always ask me and stop me in between. Don't let me talk and you guys lost in the lecture. Okay, presentation of type 1 DM. So you've got the classic hyperglycemic state. Okay, where presented with polyuria, polydipsia, and weight loss. And then you've got DKA. In fact, actually I think more than 30% of those with newly diagnosed type 1 DM presented with DKA. Okay, and the rest is actually silent. This is when the silent type 1 DM are those who detected early because of the screening. So diabetic education, so these are 8 subjects that you have to talk to your patients. When you discuss about diabetic, for example, in long cases, so these are the things that you have to focus. Okay, you have to present, even in your history, in your patient's education, in long case, even in your exam, these are the things that you have to focus. Okay, first, whether you have to ascertain whether the patient understand the DM itself. So if the patient got type 1 DM, type 2 DM, they have to understand what does it means. Okay, what it signifies. For example, if you got a child with type 1 DM, sometimes they compare themselves with their mother or their grandmother with type 2 DM. So they think, sometimes they thought, oh, why my mother is older than me, she didn't need insulin, so why do I need insulin? So you have to make sure they understand the difference. Okay, the obvious difference between type 1 and type 2 DM. And then you have to discuss with them the insulin therapy. Okay, why they need insulin and how the insulin works, the importance of insulin, how to adjust insulin, so on. And then the diet. Okay, similar to type 2 DM, so they need diet as well. Okay, type 1 DM also need a special diet. Sekejap. Blood glucose monitoring, Because the hallmark of type 1 DM, okay, the hallmark of the treatment of type 1 DM is the insulin and glucose monitoring. That is the most important thing. Insulin and glucose monitoring. Because this is the main contributor to your HbA1c. Later I'll talk what is so important about HbA1c, okay? And then you've got hyperglycemia, sick day, and DKA, exercise, and complication. Okay, these are the 8 things that you have to discuss with your patients, and you have to discuss in your long case and also in your daily clinical practice. So, what is HbA1c? Anyone? What is HbA1c? Anyone not answer?
This glycosylated hemoglobin, where actually it is average of the blood glucose concentration for 3 months.
Okay, good. Kenapa for 3 months?
Because of the RBC lifespan is 120.
Okay, good. So it's a type of HbA, okay? HbA, you ada HbA1, HbA2 kan? You've got 2 HbA, HbA1, HbA2. That's why in your HbA analysis, you've got HbA1, HbA2. Okay, HbA1, their subtype. You've got HbA1A, HbA1B, HbA1c. Apparently, HbA1c is the most stable. Compared to HbA1A, HbA1B, HbA1c is the most stable, and that's why we use it. And all this will be glycosylated. So that's why we monitor the HbA1c. Okay, as you correctly mentioned, this is HbA. Okay, HbA, glycosylated HbA. So in which case, yang HbA dia is abnormal. Patient, in which situation the HbA is abnormal that may affect you punya HbA1c level? Anyone?
Hemoglobinopathy.
Okay, especially thalassemia kan? Okay, in thalassemia. So that's why in thalassemia, HbA1c can, most of the time it is actually higher lah. In thalassemia, it can be, no, it's actually lower. It's actually lower in thalassemia because the time span of HB is lower lah. It's shorter in thalassemia. But occasionally it can be higher. It depends on the type of thalassemia. That is the thing that we still not understand, okay, about HbA1c. How thalassemia affect HbA1c. There's a lot of theory behind it lah. And then what else? When is the other time that HB is HbA1c will not be that accurate?
Pregnancy.
In pregnancy, okay? Especially in the first and the third trimester. HbA1c is more stable in the second trimester. Okay, besides that, patient with iron deficiency also you get problem with HbA1c, because in iron deficiency, your HbA1c usually very high, because if you got iron deficiency, you've got prolonged, your body compensate by having a prolonged lifespan of RBC. Your RBC will live longer. So do your HbA1c. It will increase. Okay. And then genetic predisposition also different. We know from a lot of genetic study found that HbA1c in Asian is higher. Okay, it's higher in Asian with the same control. Okay, with the same glucose control, because there are a few other parameter of glucose control lah besides HbA1c. So with similar glucose control, Asian has higher HbA1c. Okay, so what are the marker that you know that we can use to determine the glucose control over a period of time?
Serum fructosamine.
Fructosamine, good. How long does it last? It reflects the period of the control over 90 days lah. Okay, fructosamine is about 90 days. 90 days, 2-3 months. It's about 90. It's about 90 days. HbA1c can up to 100, 120. Fructosamine, fructosamine is about 2 weeks. 14 days or 2 weeks. I think it's about 2 weeks. Fructosamine, 2 weeks to 1 month. So you can repeat fructosamine monthly. Okay, tapi HbA1c you cannot repeat monthly. It won't change. Okay, it won't reflect anything. Okay, and then now people are proposed. We've got glycosylated albumin. These are some of the things that that are used in research setting. Okay, glycosylated albumin is the other things that we are using now lah. Okay, but apparently HbA1c, a lot of study done. Okay, the problem with HbA1c is we know that HbA1c is the best. We got surrogate marker of glucose control. Okay, so because we cannot determine the glucose control of someone besides using a marker lah that we can actually measure objectively. However, HbA1c does not correlate very well with prognosis. Even though we know that those with very high HbA1c, then that correlates well. But those HbA1c in between the medium range, these are not correlates well with the mortality and also with morbidity. Some people with slightly high HbA1c, they've got very bad complication. They develop retinopathy very early. They develop nephropathy very early. They end up with vasculopathy. However, with some people with even with low HbA1c, just above normal, they can get complication. So HbA1c per se is not a gold standard monitoring to determine the prognosis of someone with diabetes. Okay, so insulin. So basically, I think this one is important. So insulin is produced by your beta cell, beta islet cell of the pancreas, Langerhans cell of pancreas, kan. And then the type of insulin. Okay, let's see the history lah. So actually, insulin has been extracted since the year 1960s, if I'm not mistaken. Before that, DM is a terminal disease lah. I mean, people die with DM. Anyone with DM, they will die. Okay, especially DKA semua. Until quite recently, until 1960s, macam then we start to have insulin. Okay, so this is your natural insulin. So in insulin, the level of insulin is varies every minute. Okay, in your body in response to your glucose level. Okay, the main aim, the hemostasis of blood glucose in your body is maintained between 4 to 6 millimole per liter. Okay, so the insulin level varies lah. It will peak upon eating upon prandial. And then insulin will actually be secreted by your pancreas in an inactive form. Okay, and it has to be, but your ribosome, okay, will produce insulin, insulin pre-insulin form, inactive form of insulin, and then your Golgi body will actually modify it. Okay, will cleavage the insulin, and remove the C peptide from the insulin, and it will actually produce pro-insulin. Okay, pro-insulin will be secreted. So the C peptide, okay, every insulin molecule will come together with your C peptide. Okay, so in order a indirect way to actually measure your insulin, okay, is by measuring your C peptide. That's why in units with hypoglycemia that we suspect hyperinsulinism, we can actually measure the C peptide level. The C peptide level as a marker of your insulin level lah. Because C peptide is more stable with higher lifespan lah, with higher half-life. Okay, insulin will be secreted in the inactive form and later will be activated. So in general, insulin, there are two types of insulin. You've got your analog and you've got your regular insulin. Okay, regular insulin is your synthetic insulin lah, your organic insulin. Okay, such as you got two, which is atrapid and insulatide. This is the normal insulin, the endogenous insulin. So mainly our atrapid and insulatide are derived from animal, usually from cow lah, from bovine. Okay, so actrapid is a so insulin you can divide into two. You can divide into analog or regular insulin or human insulin. Human insulin or analog. Human is derived from most of the time is from bovine. Uh, while the analog is actually synthesized in the factory in the lab. Okay. Besides that, you can also divide insulin into the onset. Okay, into the onset and into the dia punya half life. Okay. So in terms of onset, you can divide into rapid acting, short acting, intermediate acting, or long acting. So the rapid and long acting are analog insulin. Okay. The human insulin are the short acting and intermediate acting. This is very important in your management. Okay, the rapid acting analog insulin, the onset of action between 0 to 20 minutes. About that. And then peak at 1 to 2 hours, and duration of action is only about the maximum for 4 to 5 hours. Okay, the short acting has longer duration of action, 6 to 8, but it peaks later. It only peaks after 1 to 4 hours. Okay, therefore, if you got someone with very high blood glucose, okay, if you give short acting, it will take some time to become hypo to drop. But if you give rapid acting like you bagi aspart ke novorapid kan, it will drop very quickly. You also got the intermediate acting regular insulin, such as insulatard. Okay, insulatard, the onset is 1 to 1.5 hours, with duration of action about 16 hours, 16 to 20 hours macam tu lah. And then you also got the long acting analog, which is the glargine and determine, so levomir. Okay, this one the onset is about 1 to 2 hours. There's no peak. Duration is about 20 to 24 hours. Okay, so when we talk about insulin regimen, we got conventional and also intensive. Okay, the conventional insulin, in general, this is in general you can say less than 3 injection is conventional. More than 3 injection is intensive. In adult, most of the time we start insulin by start with ON kan, with nocturnal insulin, with overnight insulin. And then after that, a lot of people they will be on mixed start, which is on two injection insulin in the morning and in the night, kan? In adult. But in pediatric, okay, most pediatrics patient, especially those with type 1 DM, we start on intensive straight. So most of them either on 3 or 4 injection per day, or using pump. Okay, why? Okay, because we want to mimic. Okay, the principle is we want to mimic the natural insulin in the body, where there's a basal kan, basal, look at here, there's a basal insulin level. Okay, and there's a peak every time feeding. There'll be a peak of insulin every feeding. So what happen if you use twice a day regimen? You got 2 peak. Okay, and the 2 peak, the 2 regimen is most of the time we're using mixed start kan. Mixed start consists of regular insulin, intermediate acting plus dengan short acting. Okay, so what happen, the short acting will peak early after 1 hour. After like 1 hour it will peak, and it will subside after like 6 to 8 hours kan. And then the intermediate acting will last longer lah, with lower peak, and will last longer. But this is definitely not the physiological. It's totally away from physiological, because you don't have like a base, a continuous base, a slow, constant basal rate. So how about the 3 times daily? Okay, the 3 times daily will mimic almost mimicking the natural insulin level, but again there'll be no base. Okay, it's difficult to get the base. Okay, the basal ni lah. And then the basal bolus is almost mimicking the natural, but yet it's not the perfect one, but it mimics almost mimicking the natural insulin secretion. So you've got prandial punya peak. Every time you feed, you got prandial peak, and you've got the basal as your basal insulin lah. Okay, what happened? What is the problem with twice a day regimen? Okay, if you give twice a day regimen, patient will have a high peak. Okay, and insulin, one of the action of insulin, it will cause hunger lah. Insulin it cause hunger. So if you give, there's a lot of peak insulin. Okay, it will cause hypoglycemia kan. Bila you ada peak, dia akan ada hypoglycemia. So bila you ada hypoglycemia, you become hunger in response to that. So you will binge eat. Okay, a lot of time if you give patient one week start, you will notice they will gain weight, of course, and they will take more consumption of calorie will be increased, and they will end up obese. Okay, a lot of time patient with twice a day regimen, they will end up obese. And then once you're obese, you've got insulin insensitivity, and then you will require more insulin. So once you start insulin, a lot of time people will gain weight and they will start to eat more and they will require more insulin, more and more insulin. That is what we call insulin stacking. So they've got weight gain and insulin stacking. With the 4 times a day, they will have less hunger, less hypoglycemia, and weight gain will be less lah. And they will be more flexible. Okay. If you got 2 meal, okay, in adult it's quite easy lah. If you want to use mixed type, the two insulin regime, because adult we only eat like twice per day, we can control. But in pediatric, because they eat like at least 3 times main course meal every day with snacking in between. So if you give fixed 2 dose insulin, they will definitely become hyper and hypo in between. Okay. And this is what intensive insulin via pump lah. CS2 is a pump. So via pump is more physiological because the pump can actually give a continuous constant amount of insulin, okay, low dose insulin continuously every like 5 minutes, continuously lah. And then each time you want to eat, patient want to eat, they can adjust the pump, so the pump will release a peak, okay, peak insulin. Ada soalan ke? Okay. Okay, in general, this one tak payah apa. This one. Okay, this is obvious lah. Basically, intensive treatment has been shown to reduce the cardiovascular and also the complication of diabetes compared to the conventional treatment lah. That's why nowadays we don't use conventional treatment. I'm not sure about that, but in pediatric we don't use conventional treatment. Okay. Okay, so what are the challenge in managing diabetes? Okay, these are the challenges that you have to understand. Okay, when you clock a patient with diabetes, or you've got clinical encounter with patient with diabetes, especially type 1DM, these are the things that you have to understand. Okay, when managing them. First, the age of patient. Okay, a lot of these diabetes patient, they are diagnosed at very young age. Okay, at 5, 4, even 2. But the more challenging children are those schooling children, 11, because they have less, they've got quite dynamic lifestyle, kan? They've got the lifestyle are dynamic, their eating habit are different than adult. They don't have fixed amount or fixed type of food to be taken, and they've got their colleague who are taking like junk food or sweets all the time, kan? So they've got a lot of challenge. There's a lot of challenges lah. And their understanding of the disease might not be as good as adult, because it's difficult. Pediatric, they are more difficult to control. You can force them, but their life is actually there's a lot of things they are facing compared to adult kan. And then the duration of diabetes now. We know the longer duration of diabetes, that can get the what we call it exhaustion. I can't remember the term, but I think it's exhaustion. So we know length duration of diabetes is associated with control. Okay, people with longer duration of diabetes, they've got poorer control. Okay, the age of patient is also things you have to think of, especially the most difficult age to manage diabetes is actually the school age. Okay, especially the young one, and also the adolescent. Okay, adolescent, they don't want to be different than others. They will choose to inject themselves, especially when they sleep over kan, they sleep over kat rumah kawan ke, ataupun dia ada camping ke, they will not comply with the treatment now, and they don't want to look different. They will keep it secret, where in fact they are on like 3 to 4 times injection kan, but they rather not do injection. Hello? Ada soalan ke? Nur Hidayah pun. You guys can hear me clearly, right?
Yes.
Boleh tu.
Tapi ada soalan, you guys just tanya lah. Stop me and then ask, okay? Okay, so the age of patient, duration of diabetes, lifestyle, your target metabolic control. Because in pediatric growing child, okay, our target is slightly lower. Now we know the best HbA1c is 6.5, but usually in young children, we allow slightly higher lah. The normal is between 7 to 8 are still considered acceptable. 7 to 7.5 is still considered acceptable in very young growing child. Okay, but those with long duration diabetes or teenagers, usually the target is similar to adult 7, 6.5. Okay, and then preference of the carer of patients. Sometimes patient are not willing to have 4 injection, then we have to give way lah. So we have to give 3, even 2 injection. Okay, so how much insulin does a patient need? Other endocrine hormone problem. Remission phase. Okay, partial remission phase ni what we call honeymoon period. Okay, those with newly diagnosed DM, kan, DM type 1, they've got this phase post diagnosis. They've got this phase what we call it partial remission phase, where they are very sensitive to insulin. So with even small amount of insulin, they can become hypoglycemic. So usually the requirement during newly diagnosed DM type 1 patient are usually around 0.5 IU, international unit per kilo per day lah. Okay. However, some patient may lose the partial remission phase, especially those that presented with DKA. Older children or those yang presented with DKA at diagnosis, they don't have this partial remission phase. They usually require high amount of insulin from beginning. Pre-pubertal children usually is about 0.7 to 1 now. So what happens is, those newly diagnosed young children, they will be started on 0.5 international unit per kilo per day, about there. And then after 1 year, they will start to lose the remission phase. So they will require higher insulin, about 0.7 to 1. However, during puberty, the requirement may rise above 1, even sometimes more than 2. Okay, 2 unit per kilo per day, because when puberty sets in, you've got a lot of growth hormone, you've got a lot of the steroid hormone kan. These hormone are actually counter insulin hormone. It will cause, even sex hormone will cause we call insulin insensitivity. Okay, it will reduce your sensitivity, the tissue sensitivity to insulin, and it will also in type 2 DM, for example, they will have less insulin now. So this is when insulin requirement will be higher, up to 2 units. But usually after the onset of puberty, after like 20-year-old, you will notice that the patient will need lesser insulin. Okay. So the next important thing is what we call medical nutrition therapy. Okay. So medical nutrition therapy is managing DM, type 1 DM is not only about insulin and glucose monitoring. Okay. Oh, I didn't mention about glucose monitoring. Okay. How much glucose do you want to aim? Do we want to aim? Okay. So in general, we want to aim because physiologically, our body maintain the glucose level between 4 to 6. So that's what we want. That's the level that we want to. But in like growing child, we allow 6 to 7 or 6 to 8. Okay, because we don't want them to become hypo. But in older child, we want them to get 4 to 6, especially preprandial. We are talking about before meal. So before meal, so they have to check at least 3 to 4 times per day now, at least, which is before breakfast, pre-breakfast, pre-lunch, and also pre-dinner, and one before bed. Okay, for the one that before bed, we allow higher, 6 to 8, or even 10 points sometimes. Okay, because during sleeping we will be hypo, kan? We will fasting, and this is when hypoglycemia can develop during sleep. Okay, that's why usually one slightly higher BSL before, higher sugar level before sleep. But between meal, in between before meal, we want 4 to 6, 4 to 6. Okay, and okay. So next, what is medical nutrition therapy? So medical nutrition therapy is the therapy of diabetes. Is a nutrition therapy lah for diabetes. So in diabetes, especially in type 1, okay, it is very important to control what you eat, okay, what the child eat, okay, because you cannot just give insulin, you cannot just allow the child to eat whatever they want, and then control the sugar by using insulin. Because as I mentioned just now, the problem with insulin is you can actually allow just the child to eat anytime they want, anything they want, but the problem is the more calorie they took, the higher the insulin they require. Okay, the higher the insulin they require, the more weight gain they will receive. Okay, they will get higher weight gain lah. Okay, they will increase in weight and they will become less sensitive to insulin, and finally you get the insulin stacking. So you have to increase the insulin, increase further and further, which actually this is not good because at the end they can develop metabolic syndrome in at the background of type 1 diabetes. Okay, they can even get hypertension and everything lah. So medical nutrition therapy can be divided into basic and advanced. Okay, usually we divide it into L1, L2, L3, level 1, level 2, and level 3. Okay, level 1 is just simple food categories. So for example, what we did is when you teach parents and also children on how to manage how to determine their insulin level, insulin dose. So those with less commitment, low socio-economic, low education parents, or parents that are very difficult to be taught. So this kind of family, we will teach them the food categories. So before they eat, okay, before they inject themselves with insulin, they just look at picture and decide, okay, oh, I'm going to eat rice. How many rice? 1 cup of rice. And then you have to inject yourself with 10 unit insulin. So that's how they calculate it. So in pediatric, we don't use fixed dosing like adult. Okay, we use either food categories, carbo counting, or glycemic index. Okay, glycemic index or food level. So those with the lowest level, we use food categories. They will just use image lah, image of food, and they will decide the dose based on the image on the catalog. Carbo counting is when we ask them to estimate based on the size, the portion of food and the type of food. This is slightly more complicated lah, where they have to determine the type of food, then the size of the portion, and then they have to consider, oh, ada tambah, so tambah curry sikit. Okay, 3 spoon of curry on top of the rice. Or this is a fried rice. Fried rice masak dengan butter, for example, ataupun butter prawn rather than sambal prawn kan, prawn sambal. So the slightly higher level of medical nutrition therapy is using carbo counting. And we will teach them carbo exchange. For example, 15 grams of carbs will exchange to 1 unit insulin. So everyone will have different exchange based on their insulin sensitivity ratio and also their insulin carbohydrate ICR and ISF, insulin sensitivity factor, and also insulin carbohydrate ratio. This one I'm not going to touch here, it's very complicated. But in general, that is the second level, carbo counting. So when you meet someone with diabetes, kind, especially type 1, ask them, okay, how you determine your insulin level? Is it by carbo counting? Is it by food category, by looking at catalog, or by glycemic index, or you actually read the nutritional info? Okay, this is the higher level lah. The highest level is actually dosing using GI and also using the nutritional info. So they read everything that they eat, they will read. Okay, how many carbohydrate, how many fat, how many protein, so how much they will, and they will decide on how much to inject. Okay, so that's it actually. Okay, so energy that energy requirement in pediatric type 1 DM. So the total calories is about between, so in general the food has to consist of 50 to 55% carbohydrate. Okay, fat between 25 to 35%, protein between 15 to 20%. Okay, in terms of calorie, okay, daily first year of life you need about 1000 kilocal per day lah. Okay, for the first year. And then after that, second to 11 years, you add another 100 kilocal per year. So if you are 12-year-old, if you are 2-year-old, then your calorie requirement is 1100. If you are 10-year-old, so your calorie requirement is about 1900. Okay, for 12 to 15 years old, you add 100 kilocal, okay, per year. For example, if the child is 12 years old kan, so 12 years old girl, so the calorie requirement will be 2100. In boys it can be up to 3000 kilocal. Okay, because this pubertal child lah, pubertal teenage kan. After 16 years old, you just need a small amount of calorie. Okay, this one, for example, if you are like 50 kilo, for example now kan, if a girl, or if you are 50 kilo, you've got 50 kilo body, then you've got a moderate lifestyle, then your calorie is only about 2000. Okay, don't eat more than that, you become fat lah. Okay, for fiber, okay, age in years plus 5 gram of fiber per day. So I doubted any of us here took enough fiber, because this is fiber requirement for all of us. Okay, for example, like myself, like I'm, okay lah, I don't tell you guys my age lah, tapi assuming I'm 25-year-old kan. So 25-year-old plus 5, so about 30 grams. So I need to eat 30 grams of fibers. 30 grams of fibers is like banyak gila. Okay, so 1 cup of fibers, 1 cup of green vegetable only contribute, I think, about 2 gram, 4 gram, I remember. 1 full cup now. 1 full cup of green vegetable only contribute, I think, about 5 gram of fiber. So in a 25-year-old, you need 30 gram of fiber. So you need 6 cup of green vegetable per day. So who cares to eat that much kan? And then you need vitamin, minerals, sama je lah. Okay. So in general, management of diabetes in children, it has to be individualized. Dietary history is very important. You have to assess an individualized plan. Okay, follow up is between one month, but usually 3 to 6 months. And then you have to assess the growth, psychosocial, lifestyle, dietary problems, because this is, remember, this is a chronic disease. So a lot of them end up with psychiatric problems, especially depression and so on. Compliance is very important. And then adjustment of insulin, blood glucose is very, very important. That's why the hallmark of management in diabetes is based on the blood glucose at least 4 times per day. Okay, and also the insulin. I remember it is very expensive to have diabetes. It's very, very, very expensive. Just imagine, one strip of glucose, though, it costs you about 50 cents. Okay, one strip costs you about 50 cents. Okay, a lancet costs you about 10 cents now, about 10 cents per day. Okay, lancet costs you about 10 cents per day. Strip is about 50 cents per day. So it costs about 2 ringgit per day just to check your glucose. Okay, so 2 ringgit per day, 30 days is 60. 30 days. So it's about 60 ringgit. Bukan 50 cent. Sorry. It's about 2 ringgit per strip. 1 ringgit lah. About the cheapest you can get is about 1 ringgit per strip. So in a day, it costs about 4 ringgit. So in a month, it costs about 120 ringgit. That is only for your blood glucose strip lah. 120 ringgit. And then your insulin some more. Okay. Some people they need to pay for their insulin, especially those yang tak sekolah kan, yang kat private memang kena bayar lah. Yang government semi subsidized, but in general it's very expensive lah. It's expensive for those, especially those socioeconomic. On top of that, if you are ill, then you have to more frequent monitoring. Lepas tu, and then the pump kan, insulin pump. If you are using pump, okay, a pump costs about 10,000, 10 to 20,000 per pump. Okay, and it lasts about 1 year lah, 1 year, 2 years, up to 3 years lah, a pump. And then now we've got a more high technology. We call it, we got CGMS, continuous glucose monitoring system, where you don't have to prick yourself. Okay, you just integrate a monitor into your pump. So you've got 2 injection lah. You've got 2 entry on your abdomen. Satu untuk release insulin. The other one is actually to monitor your sugar. Or you can also have just one injection je lah. So this machine, the CGMS, will actually monitor your sugar level every 5 minutes. So every 5 minutes, they can detect your interstitial sugar, glucose level, and it will inform your pump to direct the pump to give how much insulin. So this is, we call it artificial pancreas. Okay, this is what we call artificial pancreas now, because it works similar to pancreas, not that effective, but it's quite similar to pancreas. Okay, so these are the things. Okay, this is what I have mentioned: basic carbo counting, basic using the first step is the level 1 is just basic. Look at the catalog. And then level 2 is carbo counting. Level 3 is the concept of ICR lah, insulin carbohydrate ratio, advanced carbo counting, and also glycemic index. Okay, this is what we call carbo exchange. So half cooked rice, for example, if you look at the diagram, half cooked rice equals to 15 gram. Okay, 15 gram carbohydrate. Half cooked rice. Okay, mihun kan, half cooked mihun is equals to half cup. Half cup mihun equals to 15 gram. Okay, so 15 gram, for example, if a child got insulin carbo ratio of contoh 1 to 10 kan.
Assalamualaikum. Sorry, Dr. Alwi. Is it possible if we stop at 3 because we have class with Prof. Nasir after this?
Okay, definitely. Okay.
Thank you.
Okay lah, so ini je lah. So just imagine kaya, one kaya got 3 teaspoon of sugar, which is about 15 gram sugar. Macam lah. Okay, GI, this one important. Okay, this one not important. Okay, hypoglycemia, okay, is blood glucose less than 4. So this is what you have to do lah if you got hypoglycemia. Okay, sick day, again, hydration, nutrition, and you have to do not omit your insulin because when you sick, you've got cortisol, your stress hormone that will increase your sugar level. The most important is check your glucose level frequently. That's all. Exercise. Smoking effect and down phenomenon is very important. If you got a child with early morning hyperglycemia, so you have to determine whether this is because of somogi or because of dawn. Somogi is when you give too much insulin pre-bed. Okay, the pre-bed glucose is low, you give too much insulin, so they become hypo in the night. Early morning they become hypo, so in response they release more growth hormone, more cortisol, so they become rebound hyperglycemia in the morning. Down phenomena is usually in pubertal children. They have no hypo in the night, but because the growth hormone and also cortisol released in early morning leads to hyperglycemia in the morning pre-breakfast. I think that's all actually. So that's all. Any question? One question before we end. Any question, anyone? If not, we'll stop one. No question. Okay. So the tanggungan atas pay kafara is what to ask.